Assalamu alaikum. This is Shiri Hamid. Now we had discussed placental disorders in the last lecture. I hope you understand the topic, and now we are going to discuss the gestational trophoblastic diseases. Placental neoplasms, that is gestational trophoblastic diseases, is a spectrum of tumors and tumor-like conditions that are characterized by proliferation of trophoblastic tissue. Benign are called moles or Hydatidiform moles, and malignant neoplasm is choriocarcinoma. Both are associated with increased or persistent levels of the placental hormone beta HCG. So, even after termination of the pregnancy, or like if there were beta HCG levels were raised previously, they continue to rise and they keep on rising if there is a neoplasm, placental neoplasm in the uterine cavity. This is a villus. Now, villus normal vascular villus structure. This shows upper top layer is of syncytial trophoblast, more epithelial looking cells with the central nucleus, some multinucleation you can see, and with the eosinophilic cytoplasm. And there is an inner layer of cytotrophoblast with more clear cytoplasm and a central nucleus. Inside the villus, you can see there are very vascular structures, like it's very vascular, and there are variable size vessels within the villus. Hydatidiform mole. Basically, Hydatidiform moles are characterized by cystic swelling of chorionic villi we had seen before, and it's accompanied by trophoblastic proliferation. It can be a precursor of a choriocarcinoma, that is a malignant condition, and the incidence of Hydatidiform mole in USA is 1 per 1,000 and 1% in Indonesia. It is also called non-invasive mole or a common benign variant, but it can be invasive, it can invade as well as. Complete, further it is divided into like complete mole or a partial mole. In complete mole, there is 2% chances that it can lead to choriocarcinoma, while in partial mole, there is 0% incidence. Grossly, there is a characteristic picture of a mole. Complete, indeed the complete mole. There are grape-like structures or swollen villi that protrude out from the uterine cavity. This is the gross picture. Characteristic, you can see the swollen grape-like villi that can be easily appreciated on the gross specimen. The histopathological features, this is the histopathology of the villi. Now you can see these villi are very much, they are dilated, there is cistern formation, and they are non-vascular. You can hardly appreciate any vessel within these villi. And around these villi, there is a circumferential proliferation of the trophoblastic tissue that is complete in complete mole and it's partial in partial mole. Histopathological features of a complete mole is extensive cavitation, cystic spaces formation. The villi are swollen, they are dilated, and as we had discussed that they are surrounded by a layer of syncytial, lined by syncytial trophoblast and cytotrophoblast. So the trophoblastic proliferation is circumferential. It's hyperplasia, and they also show some kind of cytologic atypia as well as. Now, gestational sac, amnion, umbilical cord, and fetal tissue, they are not found in complete mole, but you can see these structures in partial mole. Now, genetically complete mole, basically it arises from an anuclear, an empty ovum that loses its genetic material and is fertilized by a sperm, single sperm, or that duplicates its genetic material, or by two sperms. So the chromosomal material that is in complete mole is completely of paternal origin, and they have a karyotype that is 46XX. Now, partial Hydatidiform mole. Partial Hydatidiform mole have two populations of chorionic villi, one of normal size and other hydropic with focal trophoblastic proliferation. The lesion has a triploid karyotype. Histopathological features are the partial moles are characterized by four features. There are two populations of villi, one are hydrop and they are dilated, and one population is of normal variable size vascular villi. There is minimal trophoblastic hyperplasia that involves only syncytial trophoblast, and there are enlarged capitated villi, but you can see some nucleated RBCs or blood vessels within the villi. Other villi are with scalloped borders, often contain focal trophoblastic proliferation and inclusion. Scalloped means they are indented or like someone has eaten this villi. So this is the characteristic like seen in partial mole. Stromal blood vessels in partial mole often contain nucleated fetal RBCs, and that suggest fetal development, including portions of the chorionic sac. You can see amnion, umbilical cord, and embryonic fetal tissue can also be seen in partial mole. Genetically, partial mole has a triploid karyotype that results from fertilization of an apparently normal ovum by two sperms with that fuses it identified as partial mole. There they have a triploid karyotype, and these fetuses have multiple congenital anomalies and growth retardation, and they present with triploidy. Triploidy. Now this slide compared the features of complete with mole with partial Hydatidiform mole. Complete mole karyotype is 46XX or XY, while in partial mole it's triploid. Now villus edema. All villi in complete mole are dilated and edematous, while in partial mole some of the villi are dilated. Trophoblastic proliferation in complete mole is diffuse and circumferential, while in partial mole is focal and it's slight. Atypia is often present in complete mole while it's absent in partial mole. Serum beta hCG levels are elevated in complete mole, while they are elevated in partial mole, but the levels are less as compared to complete mole. Beta hCG in tissue is positive with strong diffuse positivity in complete mole, while there is focal positivity in partial mole. Now, complete mole 2% can lead to choriocarcinoma, while it's rare, or the partial mole never lead to choriocarcinoma. Invasive Hydatidiform mole is defined as villi of Hydatidiform mole that invade within the myometrium or its vascular spaces. Clinical diagnosis of invasive mole can be suspected when beta hCG levels continue to rise even after evacuation of a mole. Pathological features. Grossly invasive mole in the uterus present as irregular hemorrhagic masses that penetrates the myometrium, and it grows through the myometrium. It can perforate the serosa and broad ligaments and adnexa, while most of the invasive moles, they follow complete moles and have the characteristic histologic features of that lesion also. This is the photomicrograph. A photograph labeled as A shows a section of a uterus in which the myometrium, you can see this are spaces or dilated villi or cavities within the myometrium. These are basically the villi that invade into the myometrial tissue. And adjacent to that photograph cross picture, you can see the histological features of us that shows the mole that had invaded into the myometrial tissue. Now, the main thing that differentiates benign tumors from the malignant trophoblastic neoplasm is invasiveness of the trophoblast. So, if the trophoblast that shows invasive features or it invades, it's malignant. Choriocarcinoma, it's like before even getting diagnosed, they invade into the, through vascular invasion, they invade into lung or different other structures. Like invasive mole, it also invades within the myometrium tissue. So the main feature that differentiate, as we had discussed previously, between the differentiating features of benign and malignant, the main feature that distinguish from benign from malignant neoplasm is metastasis or invasiveness. Trophoblastic tumors. Now, gestational choriocarcinoma, it's a malignant neoplasm. So it's composed of large sheets of biphasic, markedly atypical trophoblasts without chorionic villi. So that is the feature. Like you will not see any chorionic villi in choriocarcinoma, but it's most biphasic neoplasm. You're going to see both cytotrophoblastic tissue and syncytiotrophoblasts. Gestational choriocarcinoma may occur after molar pregnancy, like 50% there is chances, or after an abortion, 25% of the cases, and even after a normal gestation or an ectopic pregnancy. In rare cases, intraplacental choriocarcinoma is diagnosed immediately following pregnancy from placental pathological examination. Morphologically, the choriocarcinoma is characterized by grossly as a soft, fleshy, yellow-white tumor that had tendency to form large pale areas of ischemic necrosis. Now, an extensive hemorrhage or cystic foci of cystic softening. Microscopically, the classic pattern of choriocarcinoma is bilaminar, biphasic, and there is alternating arrangement of mononucleate trophoblastic tissue, cytotrophoblasts, and syncytiotrophoblasts. Intermediate trophoblasts in choriocarcinoma may show wide variation in degree of cytologic atypia. Nuclear pleomorphism and hyperchromasia is also striking, and nucleoli can be seen. And vascular invasion is very prominent in choriocarcinoma. Choriocarcinoma, like it invades through the vessels into the lungs. Chorionic villi, that is not a component of choriocarcinoma. You are not going to see those villi you had seen in complete or partial mole in choriocarcinoma. choriocarcinoma usually lacks the intrinsic endothelium-like vascular channels in the center of a tumor. So it's a unique malignant solid tumor. This is the gross picture. As you can see, there is a hemorrhagic, bulgy mass within the myometrial cavity, and it invades the uterine wall. The color of the mass is like it's red and yellow, and more hemorrhagic looking. The next picture to that of the gross picture shows the microscopic features. You can see both population of cytotrophoblasts and syncytiotrophoblasts. Syncytiotrophoblasts shows more nuclear atypia, and the cytotrophoblasts contain a mononuclear nuclei and a clear cytoplasm around them. This is the high power view of the histologic picture of the choriocarcinoma. There is extensive necrosis and hemorrhage you can see in the choriocarcinoma. Now you can see these bizarre abnormal cells, and look at the pleomorphism that and the mitosis and multinucleation of syncytiotrophoblasts, and those are mixed with cytotrophoblasts, in which you can see those cells which with these cells with a single central nucleus and a clear cytoplasm around them. And now these and adjacent to these cells are these bizarre looking abnormal cells which contain this hyperchromatic nuclei, some with multinucleation, and you can also appreciate mitosis. Immunoprofile. All trophoblastic cell types are strongly immunoreactive for cytokeratins. Syncytiotrophoblasts are also reactive for beta-HCG and weakly for human placental lactogen HPL. Intermediate they shows the opposite immunoprofile. Treatment of choriocarcinoma is the evacuation of contents of the uterus through surgery and the chemotherapy. Now, the results of chemotherapy in gestational choriocarcinoma are excellent. They have resulted in 100% cure rate or remission in patients even who had a high risk, but those cases who had high risk metastatic trophoblastic disease, or they had metastasized to different organs like lungs or other tissues, they have less response to chemotherapy. Placental site trophoblastic tumor. It's a main monophasic neoplasm and is composed of intermediate trophoblasts and cytotrophoblasts without a significant population of syncytiotrophs. Placental site trophoblastic tumor comprises less than 2% of gestational trophoblastic neoplasms, and they present as neoplastic polygonal cells that infiltrate the endomyometrium. They can precede by normal pregnancy, 1/2 of them, or by spontaneous subartion, 1/6 of them, or highest by Hydatidiform. Histopathologically, placental site trophoblastic tumors are comprises of medium to large size mononuclear cells. Some multinucleation can be seen, and there are marked nuclear atypia, prominent nucleoli, and the cytoplasm is clear to eosinophilic. Scattered mitosis can be seen, and some intranuclear coagulant inclusions. Now, the features of these cells, these trophoblastic cells, they permeate or invade the myometrium and the vessels. This is the gross picture of the placental site trophoblastic tumor. As you can see, this neoplasm is a hemorrhagic neoplasm that invades or infiltrates the uterine wall completely. And this is the histologic picture. As you can see, these are polygonal pleomorphic cells with some multinucleation with prominent nucleoli, and these are surrounded by a clear or eosinophilic cytoplasm, and mitosis can be seen. So These are basically intermediate trophoblasts or cytotrophoblasts. So there is a monophasic or a single population of trophoblastic tissue that proliferate and invade the endometrium. Epithelioid trophoblastic tumor is a tumor that is again composed of monomorphic population of intermediate trophoblastic cells that resembles those of membranous choriocarcinoma. Tumor cells of the epithelioid trophoblastic tumor are smaller and they are less pleomorphic and they grow in a pattern. This is the histology picture. Now you can see these epithelioid neoplastic aggregates that instead of a single cell infiltration, these tumor cells, they are in aggregates, or they are more like a carcinoma or epithelial in origin, and they invade the myometrial tissue. Now these are like as you see this one high power view of one of the nodule. This is comprises of this monotonous looking small size cells with some with prominent nucleoli, and they invade the myometrium or underlying tissue in these clusters or in groups of neoplastics.